Witam Państwa serdecznie.
Ladies and
Zaczynamy
gentlemen, a warm
konferencję.
welcome to all of you.
Witam
Let us
Państwa
start our
słuchających nas.
conference.
Witam
I would like
Państwa
to welcome
na
those
sali, na
joining us
kopcu
online and
Kościuszki
those
w Krakowie.
joining us
Po raz
offline at
pierwszy,
the
proszę Państwa,
Kościuszko
od 3
Mound
lat
in
spotykamy
Krakow.
się
For the first time
tutaj
in 3
wspólnie
years,
po to, żeby
we're meeting
otworzyć
together in
18.
person
konferencję
to open the
Evidence-Based
18th Conference of
Healthcare.
Evidence-Based
Sympozjum w tym
Healthcare.
roku, proszę
This
Państwa,
year's
ma 7
symposium
sesji
has
i
7
w ramach
sessions.
tych sesji, proszę Państwa, będziemy mówić o różnych
During
kwestiach,
these sessions, we will
zaczynając od,
discuss
czy
a
warto
wide range
mierzyć
of
value
issues.
w
We will
ocenie
discuss whether it
technologii
is worth
medycznej w
measuring
ogólnie w
value
systemie
in
opieki
HTA
zdrowotnej.
in healthcare
Wiele
in
sesji,
general.
proszę Państwa, będzie miało wymiar mieszany.
Many
zarówno
sessions
będziemy
will
mieli
be
speakerów
hybrid
dotyczących
ones. We will
z
have
Polski, z
speakers
zagranicy,
from
jak co
Poland,
roku.
from
I
abroad,
będą one
as
zarówno
every year.
nagrane, ale także
We will
będziemy
have some
mieć
recordings
speakerów
played
na
out to
żywo.
you,
Jak
but
widzą
we will
Państwo,
have
siedzimy
some
w pięknym
speakers
miejscu,
joining us
w
live
pięknej
as
sali.
well.
Jest
We're
z
sitting in
nami,
a beautiful
sporo
room in a
osób na
beautiful
sali.
venue.
Mam
We have
nadzieję,
quite a lot
że
of people
po sesji
joining us in the
otwierającej
room,
będziecie Państwo
and I
mogli
hope that after
uczestniczyć
the
także
opening
w
sessions,
sesji poświęconej
you will also
międzynarodowemu
participate
rozwojowi
in
HTA,
the
w której
session
mamy
on the
gości
international development of
przedstawiających zarówno to, co się dzieje na
HTA.
poziomie
We have
europejskim, jak i,
invited guests to discuss
także w
European developments, but
międzynarodowym.
also
Kolejna
international
sesja
ones.
będzie poświęcona
The
samorządom i
next
wyzwaniom
session
w
will focus
samorządach,
on local
szczególnie,
governments and the
że
challenges that they are
ocena
facing,
ewidensu
especially
czy dowodów
that
naukowych szeroko pojętych coraz bardziej
assessing
w Polsce ma
evidence
znaczenie i widać,
in
że
Poland is
samorządy
important.
wdrażają
And we can see
rozwiązania
that local
oparte także
governments
o
are
efektywność.
introducing
Sesja polsko-ukraińska,
efficiency-based
dzisiaj
solutions. And we have a
relatywnie długi program,
Polish-Ukrainian
zakończymy o
session,
17:15,
and we finish
poświęcona
today
temu, jakie
at
wyzwania stoją
5:15
szczególnie przed Polską,
p.m. In the last
dotyczące
session,
tego,
we will be talking
że w
about
systemie
Poland's challenges
pojawiły się nowe wyzwania dotyczące
triggered
opieki
by
nad osobami
the
imigrantami
new efforts we have to
pochodzącymi z
take
innych
to
krajów,
provide
szczególnie
care to
z Ukrainy.
immigrants
Drugi dzień,
and
proszę
refugees,
Państwa, jest
especially
dzień
refugees
poświęcony
from
innowacjom
Ukraine.
w HTA.
The second
Także
day will
w
focus on
ocenie,
innovations in
mierzeniu value
HTA,
w opiece
in
przede
measuring
wszystkim
value
interwencjom
in
systemowym,
healthcare,
druga sesja.
systemic
I trzecia,
interventions
sesja,
in
proszę
particular.
Państwa, jako wartość w opiece zdrowotnej.
And the third session of the second day
także w
will
zakresie
focus on
tego, co jest
value
istotne
in
dla
medical
pacjentów.
care.
Dlaczego,
We will
proszę
focus on the
Państwa,
patient
mówię,
perspective
mamy
and what
wartość,
is
kiedy
most
mówię o
important to
integrated
patients.
evidence
Why are we
for
talking about
enhanced
value
outcomes
when
jako
we're
tytuł
talking about
konferencji?
integrated
A z tego,
evidence
proszę
for
Państwa,
enhanced
powodu, że ocena technologii
outcomes?
medycznych
It's
wpisuje się
because
w myślenie o value,
HTA is
value
aligned
rozumiane
with
jako
thinking about
mierzone na
value,
poziomie
value
populacji,
understood
ale
as
przede
value
wszystkim
measured at the level of the
społecznej
population,
i
but also at the
oczywiście
level
z
of the
punktu
patient,
widzenia
social
oceny
value,
kosztów.
and
Dlaczego,
also
proszę
a
Państwa,
cost
dyskutujemy
evaluation.
więc z zakresu integracji? Ano
Why
dlatego,
are we
że
talking
chcemy
about
wpleść w dzisiejszą
integration?
dyskusję całodzienny i
We want to
jutrzejsze,
introduce
także
something
na
new
pytanie od
to
Państwa,
today's discussion
dyskusję
and
nad
tomorrow's
kwestią
discussion.
rosnących
We want to
liczb danych,
discuss
które
the
pochodzą z
growing
rzeczywistych
amount of data coming from
rozumiane
real
także
clinical
jako nie tylko
practice,
rejestry, ale także
defined
dane
not just as
bezpośrednio
registries,
pobierane
but
z
also as
systemu
direct
czy
data
szpitalnym
taken from
internetu
hospital
oraz
systems
dotyczące
or
rozwoju
other
big data.
sources,
Stąd, proszę
which
Państwa,
can
myślenie
feed
o
into big
rozwoju w
data.
ogóle, myślę, że systemu data-driven, który jest
Thinking
wpisany
about
w myśleniu,
data-driven system
jako
development
narzędzie do systemu, pojawia się
shows
kwestia,
us that
co
this
uważamy
is an
dzisiaj za
important
evidence,
tool.
co
We
dzisiaj
have to define
uważamy
what
za
we
HTA,
understand as
być może jaka jest
evidence,
nasza
how we
przyszłość
define
w
HTA,
zakresie,
and
jak to
also
oceniać
think
i mierzyć.
about
Ja na
our
pewno chcę
future
powiedzieć,
and how
że,
to address this issue.
HTA, proszę Państwa,
I'd just like to say that HTA, when we think about it, this term came up in 1978 in the US, so we can say that we are celebrating 50 years of the development of this system and way of thinking as well.
Także Europy, ale także innych krajów.
This is all present in Europe and other countries, but in different dimensions. And these discussions on the different dimensions, on the different tools and our different pathways for development is important. It's important in the face of the growing challenges of healthcare across the globe. In this context, it is key to support decision makers and thinking of ways of how to do it. I do not envy decision makers when I see how they have to cope with the challenges in the healthcare system. Let us open the first session. During this session, we will discuss HTA's perspective for the future with Michael Schlander. I'm sitting here in front of you, ladies and gentlemen. Michael Schlander has joined us from Germany. We will be talking about the future of HTA. And we hope that this session will serve as an introduction to a more general discussion. Let me invite you to the first speech by Daniel Ollendorf, who is joining us online from the USA, a member of the management board of our HTA company. He is about to change job positions, but he has served as the director of measuring value in evidence-based healthcare. And he will give us a sum up of what is happening from the perspective of international organizations. Let us listen to his lecture.
Hi, everyone, and thank you for attending the EBHC Symposium. My name is Dan Ollendorf, and I'm both an HTA practitioner and an academic researcher in the United States. I'm very sorry I couldn't be with you in person, but I hope that you enjoy my thoughts on the bright and necessary future for the field of health technology assessment. So, without further ado, let's begin. First, a disclosure. My work as HTAI Global Policy Forum Chair has involved several of the topics that I'll be talking about today, and so I will cite some of that work as we move forward into the discussion. So, famous Polish poet Wisława Szymborska, if I'm pronouncing that correctly, hopefully, wrote, "Perhaps all fields are eternal, but fields unknown to us." To me, this means that we can move forward on a path for the future for a very long time, but we don't know exactly what route this path will take. In the same way, there are uncertainties in the field of HTA and the future of HTA that we do need to consider. So how certain is the future of HTA? Well, around the world, health systems are struggling. Costs are going up, there's inadequate staffing in many locations, and budgets and resources are very tight. All of this might make you think that HTA is in a good place, as a discipline devoted to making the investments that maximize health even when resources are scarce. But the COVID-19 pandemic has taught us that HTA can be easily bypassed, especially in areas of crisis or emergency. For these reasons, it's important that HTA keeps evolving to ensure its future. So today I'm going to talk about 3 areas where HTA is starting to evolve and really does need to continue on that path. The first is that HTA should, as much as possible, embrace the technology lifecycle and rethink its processes and activities that match up to the lifecycle well. Another is moving forward on the path to advance in methods and process, to ensure that remaining scientifically relevant and credible for the stakeholder community continues. And the final area is about promoting collaboration across HTA bodies, and even with other parties, to ensure that best practices and standards are maintained, to realize efficiencies, and to provide a more consistent ecosystem. So let's first talk about HTA and the life cycle. What do we mean by the technology life cycle? Well, as this graphic shows us, technology starts with early proof of concept and feasibility study and moves into preclinical considerations. And this is the point at which many early dialogue and scientific advice consultations often occur. Then the technology moves into human study and clinical trials, and after regulatory approval is granted, an HTA appraisal takes place. Following this, if the review is positive, the technology is adopted and reimbursed, and may be considered for reassessment as more evidence becomes available. And finally, when technology is considered obsolete, it may be disinvested from, but we know that is very often a very difficult thing to do. So what kind of innovations have we seen with HTA in the life cycle? With respect to early dialogue, the Paradigm Toolkit is an exciting development, providing guidance to the patient community about how they can meaningfully engage with HTA and industry to make these conversations most meaningful and helpful. There's also renewed interest in the development of core outcome sets to make clinical trial design more meaningful to patients and caregivers, predictable for those assessing evidence, and fit for purpose for comparative research between treatments. In the regulatory space, collaboration is occurring across regulators, such as with Project Orbis, and those involving HTA, such as the innovative licensing and access pathway, which I'll talk about a bit more in a few minutes. These are intended to increase consistency in evidence standards and provide a blueprint for industry. And finally, multiple efforts have begun to use real-world evidence to reduce uncertainty around decisions that have been made, and in some cases, even adjust pricing based on performance, such as in Taiwan. So members of the Global Policy Forum also debated this topic and developed a set of recommendations to consider. Given that the largest HTA agencies have limits on their resources, there should be prioritization about what the most important lifecycle activities are. For example, doing reassessments automatically for everything may be a waste of time and resources, so a focus could be applied on the most important or highest impact topics. There was also discussion that a true lifecycle approach should consider measures of value, including new evidence and prices, to be dynamic. They can change as the nature of that evidence and the context changes. Some attendees noted that early scientific advice often feels like starting all over again, even if topics are very similar, so there should be attempts to carry through learnings from previous exercises. It was also felt that given the pipeline for new technologies is global, an effort to make horizon scanning an international activity could be worthwhile. Another potential efficiency gain might be to develop models and approaches at the disease level so they can apply to multiple technologies rather than reinventing that wheel every time. And finally, patient groups often feel that they're asked the same questions by multiple agencies and industry partners, so an investment in some sort of global repository of patient information was also felt to be worthwhile to consider. So now let's look at how HTA is starting to evolve in methods and processes. There are a number of avenues that the HTA community is taking to advance its methods and the approaches it takes to produce its key outputs. Two very broad efforts are worth noting. In 2022, the National Institute for Health and Care Excellence in England launched a comprehensive review of all of its activities and methods. The effort was open to public consultation and included reviews of certain elements by independent researchers. In Australia, a government review of HTA policies and methods has begun and will also be supported by independent academic research. The NICE effort resulted in some key changes, including use of a new severity modifier to NICE's cost-effectiveness thresholds, which replaced its older end-of-life criteria, creation of a new accelerated review process for certain technologies with what would be felt to be more advanced or more mature evidence, and more clarity on exactly what technologies are candidates for the highly specialized technologies program for rare diseases. In Australia, the review will focus on PBAC's, the Pharmaceutical Benefits Advisory Committee's review of policy and methods, or the policy and methods that it's currently using, a survey of international approaches to conducting appraisals and procuring drugs, and a review of PBAC's approaches to stakeholder engagement. The results of this effort are expected by the end of this year. Another issue that's on everyone's mind is ensuring that HTA decisions and recommendations are not only efficient, but also equitable. Will everyone get an opportunity to benefit from a new technology, or are there barriers in place that must be considered? There's a lot of interest around this in the States, where the Institute for Clinical and Economic Review has announced changes to its value framework to promote equity. And another organization, the Innovation and Value Initiative, has developed guidance for promoting equity in HTA specifically. These combined efforts have resulted in some key learnings that should be considered across many settings and countries. First, it's important for HTA bodies to hear directly from disadvantaged groups to understand barriers in detail. Whenever possible, HTA bodies should also consider the possibility that patients and others could have a seat at the table to help create an approach to considering HTA and HTA appraisals. ICER in particular has developed a novel approach to consider how diverse the populations are that are enrolled in clinical trials, which is a major concern. And of course, it's critical for HTA to understand how a new treatment might affect equity and actively discuss the results with those marginalized groups. Finally, there are advances in methods to take advantage of distributional cost effectiveness analysis, or DCEA, can help quantify those equity challenges that I've just described and the trade-offs that are associated with a natural tension between being most efficient in your decisions and being most equitable. And finally, let's turn to real-world evidence. There's now some emerging guidance from HTA bodies on how technology developers should consider real-world evidence, including from NICE and Haute Autorité de Santé in France. There are a number of applications of RWE that HTA bodies should consider, including the use of such data to gain insight into treatment effectiveness for drugs that are approved on an accelerated basis, with typically little or immature evidence, monitoring the performance and possibly adjusting pricing and other parameters after an initial decision, and understanding whether the patient experience on treatment is as expected from the clinical trial data. Guidance from NICE and Haas suggests that attention should be paid to data ownership and governance, developing standards for planning, conducting, and reporting these studies, and exploring the suitability of specific data sources for certain research questions. And in addition, the guidance includes recommendations for the development of certain RWE study designs, including cohort studies that might be used to understand patient preferences, development of external control arms for single arm studies, which are also common with these accelerated processes, and finally, doing quasi-experimental research to understand how treatments compare in the real world. So finally, let's discuss how HTA bodies can best work together with others. How and why do HTAs collaborate? Well, HTAs can collaborate with each other for specific purposes. For example, NICE, the Canadian Agency for Drugs and Technologies in Health, and ICER in the US developed a collaborative policy around accepting confidential data from manufacturers, a very specific topic. A new partnership between Australia, Canada, the UK, and New Zealand is going to work on a number of different items, including how to strengthen HTA systems for the future, involving HTA in response to the next pandemic, opportunities for HTA bodies to share some work and realize efficiencies, the best approaches to partnering with regulators, and developing a shared understanding of the impacts of digital health and AI on health and economic outcomes, something that I think we're all concerned about these days. Speaking of regulators, the HTA agencies in the UK are partnering with the regulator there to develop a streamlined approach for technologies with great innovative potential, known as the Innovative Licensing and Access Pathway, or ILAP. And finally, there are many collaborations between HTAs and other stakeholders, including patients and caregivers, industry, and payers, to make note of. So this is happening quite frequently. But what have I left out? There is one collaboration that has everyone's attention, and it's the move from a voluntary approach to conducting joint HTA through organizations like UNEDA to a regulated and mandated approach all the way across the EU. There are a number of key features of this regulation that hold some promise for increased efficiency, including joint scientific consultation and early advice, joint clinical assessments, a separate and hopefully streamlined path for emerging technologies, and development of a centralized network of stakeholders. But there are also many unanswered questions, including whether joint assessments will be conducted under just a few scopes or many. How much efficiency will industry really see if all economic evaluations will continue to be local? And how long will these assessments actually take to complete? We will see how things shake out over time. So to bring this all together, I strongly feel that health systems and governments will need the discipline and rigor that HTA brings for a long time to come. But ensuring that stakeholders understand this requires that HTA continuously evolve. There's also a need to better match what HTA is doing to key points in the technology lifecycle, continue to reinvent the state of the art when it comes to delivering HTA, and embrace collaboration when this is feasible to realize efficiencies and create best practices. So I thank you very much for your time today, and I hope that you enjoy the rest of the symposium. Here's how to get in touch with me. Thank you.
Thank you very much. Dziękuję bardzo. Proszę Państwa, to była pierwsza otwierająca.
Ladies and gentlemen, that was the first opening of presentation. As you can see, the evolution is happening on a global level and in different countries. And now I'd like to start with Michael Schwander.
And the next presentation, Changing Perspective on Value and Valuation. This presentation will be focused on economic part more, but also the different parts, how to assess the values, because the tools and numbers of the approaches are growing. Michael is our professor of economics from Mannheim and also Heidelberg, and he also is the director of the health economics in the Center of Cancer Research in Heidelberg, and he is also the responsible and we can say the president of the Institute of Innovation and Tariffs in Healthcare in Germany, and he is also different approaches and cooperations and abroad, and it's interesting because he is a medical doctor and economist, and it's a little different thinking than you connect this to a discipline. Michael, the floor is yours.
Magdalena, do we need to switch on?
Justyna? Mikrofon nie działa, czy coś? Przepraszamy, mamy problem techniczny.
Sorry, we have a bit of a technical hitch. The microphone is not working.
Just a moment, okay? Justyna, nadal nie... Przepraszam Państwa. Okay.
Yeah, Magdalena, many thanks for the invitation. It's a pleasure to be here with you. I have to say I haven't been that often in Poland, but I have always enjoyed the short stays that I could have here. And maybe before I start, two things. One is I will talk about a few old things and then move to new things. And the combination of the old thinking and the new is often what makes the best outcome, actually. What you should know, and that is before I start, that is before I came back to academia in 2002, actually my primary background was, I'm a medical doctor and an economist, but I worked for 15 years in the biopharmaceutical industry in a number of functions internationally. I think that is what you should know about my background in addition to my current academic functions. And I have been exposed to the beginnings of HTA during that period, including the inauguration of NICE, from a different perspective, not just from the perspective of an advisor and a consultant and an economic analyst, but also from somebody who was concerned with market access, pricing, reimbursement. Yeah, old and new. And what are we talking about? I think there are two things that are pretty obvious. One is that the number of technological innovations that we see are outpacing our ability to pay for them. At the same time, we have the struggle that how do we regulate that? How can we assess what provides value for money that is appropriate? And then HTA, of course, comes into play as a major instrument to achieve that. Here's something about the background that I will get back to. This is what you have seen quite frequently when we look at data from Western countries. This is what you've got here, US approaching now the 20% margin, 20% of the gross domestic product being spent on healthcare expenditures. The crowd below is basically Western Europe, mostly Western European countries, and what you see is a steady increase in all these cases. And if you look at Central and Eastern Europe, I have added here for comparison the red curve of Austria. What you see is basically from a lower absolute level, this similar trend of increasing healthcare expenditures that we have to find a way to cope with. But if you look at the numbers, apart from the level of GDP, which is generally lower in Central and Eastern Europe at this point in time, at the same time, the percentage of GDP that is being spent on healthcare is roughly half that of Western European countries, Canada, US. So this has to be kept in mind when we come back to the issue of what might be an appropriate threshold actually to set limits, because setting limits is basically the key topic here. And when we talk about setting limits, obviously, it is not just about finding out what is more effective. It's not about comparative effectiveness analysis and evidence-based medicine per se. That would, in that little chart here, be finding out point A. If you have on the horizontal axis the resources that you use, and on the vertical axis the value that you create, of course you would have a typical curve like that that is reflecting diminishing marginal returns, as we see in many areas of economics. And evidence-based medicine would be concerned in figuring out what is that point A where we don't achieve any further additional clinical benefit. That's the uncontroversial part about it, about HTA also, and that is the part where we see most potential for international integration, then referred to that. The issue, however, is what about the value that we create, and that would be to identify that point B in that little chart, the point where the incremental benefit does not exceed the incremental cost that we incur, and by definition we leave a number of medical interventions between points A and B that are proven to be effective clinically out of our healthcare system for efficiency reasons. That, up to that point, is trivial. It is less trivial once we consider what should be the unit of value, because in order to make a comparison between resource use and the value or the valuation of the benefit, we need to have a common currency for both. And the traditional answer of economics has, of course, been to look at willingness to pay and to have a monetary measure. So the marginal willingness to pay would be the measure of the marginal benefit according to traditional welfare economic thinking. And for a number of reasons that we don't need to repeat here because you're all familiar with that, this has been rejected by the majority of people involved with healthcare allocation decisions. That is just another example of a non-scientific reply, the well-known quote by Oscar Wilde, claiming, well, you have to be a cynic if you know the price of everything, but the value at the end of the day of perhaps nothing. So what has been the answer that is predominantly given in health economics and as a consequence also in HTA, where health economic evaluation is incorporated? Well, we have moved out of economic welfare theory, establishing a paradigm that is dominant these days that we call extra welfarism, or that I refer here to as the logic of cost effectiveness. And the key assumptions, and forgive me if there is a certain amount of simplification here, because we cannot go into an economic seminar today and don't want to do that, but you can summarize it. We look at quality of life, we look at length of life, and we look at the probability of achieving that with interventions and take that as the measure of benefit. And then we have to assume that the measure that is integrating that is the quality adjusted life here in most cases. It doesn't have to be this particular measure necessarily, but usually we use that. We have to assume that this is fully capturing the value of healthcare interventions in order to work. We need a further assumption, that is, we need to assume that the primary objective of any collectively financed health scheme for which HTA is designed to work and which is designed to be informed by HTA findings, in order to apply that logic easily, we need to assume that the primary objective has to be to maximize the number of QALYs. And of course, again, this is not very new, that insight, but it is important to be reminded of that and to keep that in mind. That is, of course, at the end of the day, a quasi-utilitarian approach that is aggregating beyond persons, between person groups, beyond patient groups. What we see here is we have an approach that at the end of the day aggregates beyond any rights or claims-based perspective that would respect the right of an individual patient and a person. That's inherent in that logic. And you can even go one step back and say we have one very fundamental assumption here. That is, we assume that decreasing cost per QALY that we produce implies an increasing social desirability of an intervention. The result of that is to produce these famous, some would say infamous, but I think they are commonly used in economic textbooks. We find these cost effectiveness league tables or cost per QALY league tables, and the way they are presented, you know, in the traditional forms, you have maybe brain surgery and for malignant tumors at the upper end with a high cost per QALY gained, and you might have recommendations to stop smoking or something like that at the lower end. They are presented in a way that they are highly plausible, just as the logic up to that point appears to be, well, to have high face validity. And it seems that there is what we call in philosophy, and it's a concept that is always also used in decision science, that we achieve here reflective equilibrium. What we see is our moral intuitions coincide with the rational analysis, and I take rationality here, or as the logic of cost effectiveness as a rational approach. So up to that point, I could basically finish my presentation and my talk. Difficult to disagree. But let's revisit the basic assumption: the social desirability of an intervention is inversely related to its incremental cost per QALY gained. And take just a few examples, and then we can analyze what's going on, what's explaining that. But take the example of sildenafil for elderly diabetics with erectile dysfunction. Has been extensively studied, and we know that we are here in a range between 3,000 and 5,000 euros per QALY when at the time it was launched and not yet generic. Comparing against thresholds in a range of 20 to 30,000 at that time in the UK, maybe 50,000 in countries like the Netherlands. Clearly something that would have to be part of the system, clearly something that would be more desirable than what we have here at the lower part: palliative care interventions for people with comorbid conditions, something largely neglected that we can discuss about later if you are interested in that particular topic. Another well-known example, what about orphan medicinal products? What about orphan medicines, drugs for very rare diseases, where we are easily in the six-digit range of euros per QALY gained. So clearly we would have a ranking here. Sildenafil would be much more desirable in a collectively financed healthcare scheme. Tattoo removals is another example that is falling into a similar category. Very low cost per QALY gained. So highly desirable in a collectively financed scheme. Well, I guess not everybody would agree with that. And we have empirical data that indeed the majority of the population where this has been studied does not agree with that kind of prioritization. So we find here a number of interventions like children with orphan disorders, people in double jeopardy, people that not only the disabled, also people with comorbidities. We find end-of-life treatments, a traditional exception that NICE had in their system before they replaced that by their severity modifier that they introduced lately. These are things where we would intuitively say this is something that a collectively healthcare scheme should prioritize over the other parts where we have the rational analysis in favor of it, but our intuition is probably, well, it's not a matter that we should prioritize when we talk about a collectively financed healthcare system, when we talk about here sildenafil and tattoo removals and the like. So, what's going on here? Apparently, we have an issue with the fundamental assumption underlying the logic that leads us to calculate a uniform threshold. That is the maximization hypothesis. And the bad news actually for everybody using that, and I know that we are using it because it's technocratic, it can be done, it's workable, we can calculate something. The reality, however, is that if we look at the preferences of the population in our countries, wherever it has studied, we know that it is not the expectation of people that their healthcare system is indeed maximizing the number of QALYs produced. It was shown first in a systematic review in 2005 by Paul Dolan et al. From the UK, and we have a lot of literature about that we know from empirical data. The preferences of the population, the preferences of citizens are not reflected. They are not in line with the QALY maximization hypothesis. But if you have to give up that hypothesis, of course, any idea of a coherent threshold across the board collapses necessarily. But it's more than that. It's not just the myth of maximization, as you might call it. There are some further loopholes. And if you look at the way we do that, we have come up with a number of conventions that include a whole range of linearity assumptions. Recall the curve of diminishing marginal utility that we have as an almost universal economic law. And now look at the way we calculate the QALY gains. And I'm not talking about technocratic things easily, I'm talking about conventions with normative implications. I will get back to lifetime gained, that we can have a linear extrapolation from minutes to months to years to a full lifetime and have a proportional relationship to the cost. For quality of life, this is well established and accepted. Even NICE is moving in that direction, which is the right one in my view, that they have that severity modifier now for diseases. We are not following a linear relationship that, again, at the lower end is valued exactly the same as, again, at the higher end of the scale. The sildenafil example is partly explained by that phenomenon. Probability or risk is another part. What about major risk? What about immediate risk of immediate death, for example, as opposed to low risk? I could give you an example where we have the combination of quality of life and probability of risk. Take the EQ5D as a measure, and compare the situation that somebody is facing acute myocardial infarction and we can prevent that, then we have a gain on the quality of life scale of 1 immediately for the rest of their lifespan. If we had, according to the EQ5D, on the other hand, mild problems with walking and with usual activities, but no further impairment, that would result in a difference of 0.2, because we come up with 0.79 according to the tariff of the EQ5D compared to 1 in full health. So the implication would be, if we follow our logic and follow that particular instrument, I should add, that preventing 5 cases of myocardial infarction is valued equivalent. Sorry, to 1 case of myocardial infarction is valued equivalent to 5 cases of preventing mild problems with walking and usual activities. And again, you see that we probably would agree that we give higher weight to preventing the fatal myocardial infarction in relation to the trade-off and the opportunity cost regarding relatively mild problems. The final one, number of patients benefiting. I think that's the obvious problem regarding the orphan situation. We have the phenomenon of rarity, or on the other hand, of high prevalence, systematically eliminated from the way we calculate the ISA, for the very simple reason that the size of the numerator and the denominator cancel out. So we have a fundamental issue here that the ISA per se cannot tell us anything with regard to the size of a program, to the budget impact, and I think we were concerned about affordability issues in the first place when we began. So the ISA doesn't tell us anything about that, cannot by design, and more than that, it cannot integrate any preference that we might have, and again, there are empirical data that we do have such a preference, not to leave behind patients who are unfortunate to have a rare disorder. The question is, how much weight should we give to that? But I think there is hardly a question that we should give weight to it, and the way we have designed our calculation is by definition excluding any consideration of that. As soon as we start to do empirical work following that framework, by definition we cannot find any effect anymore on that account. And the last one, the qualms about qualis issue, quality-adjusted life minutes, quality-adjusted life years. That is perhaps something that is not as well known, and therefore I have an example here, which is indeed not as hypothetical as it might seem, because it's based on a real program that has been established in Belgium. The numbers are made up for illustration. Assume we got a surgical intervention for a small group of patients, let's say 1,000 cases per year, that results in post-operative pain associated with a health state worse than that, with a utility of minus 0.2 at least for 1 day. I take the minus 0.2 because we can calculate easily. If we assume we can remove that up to a state of 0.8, then we have exactly a unit 1 gain that makes it easy to calculate. And if the treatment cost of that intervention that brings patients back to a utility of 0.8 would be 250 pounds in that example, but you can replace it with any other currency, then you can easily calculate that the treatment would be associated with a cost per quality gained of 250 times 1 divided by 365 days of 91,000 pounds in that particular case. Clearly, by any thresholds that we have been using in the past, that is something that would be far beyond what we believe we can afford. On the other hand, given the size of the program, it's easy to calculate that the budgetary impact of that would be just 250,000 per year. So the question is, would we be willing to pay for such an intervention in the healthcare system? I leave the answer up to you. The question is, does that linearity assumption that we can calculate length of life irrespective whether we are talking about a few days, months, or maybe a lifetime, can we assume that we can have a linear relationship between that? And if not, we have violated another basic assumption here. So, what now? Just an aside, because we still have to talk about the threshold issue. If I haven't shattered your assumption that there is something like a threshold outside the confines of that technocratic framework, if there is something in the real world, you have to ignore all these things that we have been looking at for the moment. But still, I know that we do use thresholds, and we might, as long as we follow the logic that is well established and commonly used, we might at least ask what are indications for an appropriate threshold. And now again, you have two ways how to look at that. One is you can assume I have a fixed healthcare budget, and I look at it from the supply side. That is what has been done in the UK in particular, where there is a fixed NHS budget, and using all the assumptions, the maximization hypothesis, all these linearity assumptions, the exclusion of any other value drivers except for length of life and quality of life. Then they came up with, in the UK, 13,000 pounds per QALY, and you probably have seen the attempts to extrapolate from these data using different levels of GDP in countries and different functions of income elasticity to extrapolate what might be appropriate thresholds in other countries. But you have to accept all the assumptions underlying that. You could also take a different perspective. You could also look at what are the preferences of people. That would be a demand-side logic. If you do that, you come up with completely different numbers. And I'm not saying translate those one-to-one into the healthcare system, but I think it's interesting to look at them. And if you do that, you come up with, expressed here as multiples of GDP per capita, with reference to that 1 to 3 times GDP per capita recommendation of the WHO that is cited frequently. If you look at all the empirical studies that have been done in economics about, stated preferences, revealed preferences, discrete choice experiments, contingent valuation studies, if you take that together, then you come up with an estimate of almost exactly 5 times in Europe and 7 times in the United States. And I can give you also the raw numbers for that. That would be around about 160,000 euro in Europe, and it would be around about 270,000 euro actually per life year gained in the United States. Again, I'm not saying translate that one-to-one, and I would not even dare to suggest to translate that to other countries and to specific settings. You have to take into account not only the level of GDP, you have also to take into account, of course, the share of GDP that is spent for health expenditures that we saw at the very beginning. There are major differences. It comes into play what is publicly financed, what is privately financed, and so on and so forth. There are a multitude of factors, but this is a reminder that apparently the preferences of people, as far as we can say from empirical economic studies, would prioritize length of life increasing interventions to a relatively higher way than we do in our current healthcare systems. But now, what's left here with the thresholds? There is, of course, uneasiness with the thresholds, and we don't need to go through all of that. You find all kinds of opinions, too high, too low. Industry will say they create barriers to access. HTA agencies make increasingly these adjustments for severity, sometimes for other criteria. Sometimes we differentiate between assessment, where we calculate, and appraisal, where we bring in further criteria. In academia, it's also a controversial topic. Should we go for supply side? Should we go for demand side? Does it exist at all? As soon as we depart from all these assumptions, which I tried to draw your attention to. So we've got an issue here, but when it comes to the ISO as a measure, as the ISO as a measure to help us determine what we can afford in the healthcare system, this is old again. I started with old and new. This was an old observation. When the logic of cost effectiveness became popular, 2 Canadian researchers, Emmeram Gaffney and Stephen Birch, published a series of papers about the deficiencies of that approach and what they actually went to. They went to a wording like ISA should mean information created to evade reality, in fact, for some of the reasons that I tried to explain. So where are we left now? We have, of course, an increasing body of scientific literature that is telling us about other sources of value. And at the end of the day, if we follow that, we might easily wind up with a Tower of Babel. You know, on the one hand, we have the reductionist approach that is too reductionist, that is excluding a lot of things. On the other hand, if we wind up with anything that could have been shown to generate value, we might wind up with, for example, here, my favorite example of that value flower from the ISPOR, that is, you know, the value of hope. Are we alchemists? What are we selling actually to patients? And what are we asking to be paid for? Is it just hope? Are we wanting to have a premium for a placebo that gives people hope? Probably not. Probably we are also concerned about how strong is the evidence and how much overlap do we have between these criteria. So there is a pro of what I'm showing you here, that is that we are moving towards increasing recognition that there are important sources of value outside the conventional model. But at the same time, we are winding up with a problem how to tackle that. And I would like to conclude with giving you some hints that there are indeed ways how we can tackle that in a better way. And I've tried to come up with a ranking here between the degree that social objectives, or you could translate social objectives as non-selfish objectives, which is probably a better description of what we are talking about. How are they reflected? How can they be reflected? What methods do we have to approximate social value? And then you would come up with, well, cost-effectiveness analysis certainly is not useless, even though it is distorted and can mislead us substantially. But moving up the ladder, you find here the value assessment frameworks that have become popular, which you could see as variants of multi-criteria decision frameworks. And at the upper end here, I have the cost-value analysis proposal by Eric Nord since 1999 that has not become very successful. And what we are recently thinking about, that is a concept that we call social cost-value analysis, and just a few words about that. What does that mean? That would mean to move or to shift the perspective for the payment vehicle that we use for cost-value analysis from the cost per patient or the cost per healthcare payer to the cost per citizen. Asking people, how much would you be willing to pay for a certain intervention to be captured in the system? And then you can capture a lot of effects and a lot of preferences that are broader than just length of life and so on. You can capture how many patients are affected, what's the size of the benefit, and so on. You could continue the list. The issue is, if you ask people about what would you be willing to pay, and the payer at the end of the day will be a public service, of course people will be tending to give exaggerate statements. So what do we do about that? One way is to go for a social willingness to pay measure that has to be choice-based. So there have to be alternatives, and there has to be a payment that can be increased taxation, that can be an increased insurance premium. Still, we are at the demand-side perspective, and the demand-side perspective will give you, for example, very high threshold values, as we saw before. So we have a tendency to get values that are too high to be handled. So there is an alternative that is a relative social willingness to pay measure. So you could give respondents, population sample, citizen sample, a certain budget and ask them to allocate that budget between different patient groups, interventions, and so on. So you can reconcile a social value perspective with a system that is constrained by certain budget limits. And I cannot continue here for a very simple reason. I'm exceeding my time, I'm afraid. Magdalena encouraged me. She said we will be able to accommodate if you talk longer, but I'm
the second last slide and then the last one. The second last, that is a reminder. Why is that important? You know, the economists among you will be familiar that, of course, we differentiate very fundamentally between allocative efficiency and distributive concerns. And what we are doing in cost effectiveness analysis using QUALIS, like we do it in conventional cost benefit analysis, if we were following welfare economics, we are always concerned about optimal allocation. That is how we define efficiency traditionally. But the issue in a collectively financed health scheme is at its heart a distributional one. It's not an allocative one. And if we want to incorporate that, we need to have measures that are able to capture preferences, not only for optimal allocation, but also for optimal distribution. There is, from a systematic point, from a normative point, absolutely no reason, because of a certain theoretical concept, to exclude distributional preferences of the population. And arguably, they are particularly relevant in the allocation of healthcare resources. And this, forgive me, finally, an advert, if you want, if you are interested in going much deeper into that, because this deserves much more differentiation and much more look into how can it be done, how far are we. This is one opportunity to discuss with a leading group of international health economists, both the use of economic analysis in HTA at this point, as well as the need and the options how to develop methods further in the direction of capturing a broader range of social preferences, which I have tried to make the argument is essential for the economic part of HTA to fully capture value. And this is kind of reflecting also a discussion that we see moving in that direction, even though I would argue at a relatively slow pace at the moment. Thank you.
Thank you. I would like to move to this discussion. I would like to invite Jacek Siwiec from HTA agency, who's our also panelist. And we have short discussion regarding Jacek. Welcome. We have 20 to 25 minutes for short discussion regarding how to change maybe value measurement. And my first question may be, and I will start from Jacek. Tak, po polsku. You can speak in Polish.
Będziemy, może powiedziałbym dwa słowa o sobie.
Maybe I will just say a few words about myself, because Magda has known me forever, 3 decades or 2 maybe. Well, I've known him 20 years. I don't know how long he has known me. Either way, not everyone knows. My name is Jacek Siwiec. I am the director at the Polish HTA agency in Krakow. I deal mostly with healthcare services, creating guaranteed benefit packages. And I have been invited to be the Polish representative for the team on the joint HTA with the European Commission. So this is an element of the policy of the European Union, which will result in the change of our paradigm, the one that we're functioning right now. We are at a turning point right now, at a crossroads.
First question, I will start in English with Michael maybe, and then Jacek, okay? Michael, do you think that we are successful regarding the value measurement as a QUALI?
If we are successful measuring value with a QUALI, that's a question that I tried to address in my presentation, actually. Yes, we can measure what we want to measure. Length of life, adjusted by quality of life, adjusted by the probability to achieve that. You could, of course, discuss a number of technical issues here. For example, which instrument to use to measure the quality of life component of that model. And we know that, well, we have 4 to 6, depending on how you define that, instruments that are grounded in multi-attribute utility theory and that allow us, at least in principle, to calculate the utility index that we need for the quality calculation. We know they are different in their descriptive systems. We know they are different in their scaling and their algorithms. They are different in their sensitivity to different domains. And the result is that if you look at their psychometric properties, that the choice of instrument can make a difference of a factor of 2 when it comes to calculating differences. So we have to be careful to be aware of which instrument has been used and what does that imply in terms of discrimination against certain other patient groups. If we say we want to have a standardized instrument in order to get away from that variability, we by definition give preference to some and give less preference to others. And let me just comment to make it a bit more sharp. Let me comment on the EQ5D, because this is the measure that is most widely used, again, for a number of reasons. One is, of course, it can be conveniently being added to study protocols. It's just 5 questions for 5 dimensions. We know the leading role of NICE that have focused on the EQ5D. If you use that instrument, you will have excluded, basically, to a large extent, the sensitivity to mental health. The senses are not included at all in these 5 dimensions. And if the whole dimensions are missing, as a result, you cannot heal that by moving from 3 levels to 5 levels, as has been done. The deficiency will remain and does remain. We have other instruments like the SF6D, to quote one of the more popular ones, that are much more sensitive to mental health problems. And if you have a mental health problem and there is a system that is imposing the use of the EQ5D as a standard, then of course you are at a systematic disadvantage, and so on. So we have difficulties regarding the measurement that are technical issues, but my primary concern would be indeed that these components of value that we are interested in are not captured in the quality. So if we calculate a cost per quality ISA, we need at least to correct that by adding further criteria, which raises the question, should it be efficiency first and then some modification afterwards? Is that good enough? Or should it be the other way around? You could just as well incorporate the use of the quality into any type of broader concept, including social cost value analysis, because you could give that information also to citizens. Look, these are the qualities gained, and incorporate that into the judgment. But I would say, among all the measures that we have, the quality is probably the one that we understand best of them. So I'm certainly don't want to be misunderstood in saying now, give up on the quality and the whole systems and the whole understanding that we have built up over decades.
Okay, if we know that quality is connected with the clinical side, I switch to Polish. Jacku, jak myślisz, jak Unia...
We are switching to English. Jacek, how can the European Union help us assess the clinical part? Because the changes that will take place in Europe will impact the decades to come. Yes, this will affect decades. How do you assess how the clinical assessment and the clinical aspects be created in the development of the assessment, which will maybe be the future of HTA? It is quite likely because the target model aims at creation of a network of HTA agencies with a huge decision-making capacity and a huge impact on the drug policy throughout the European Union. The change that is happening right now is very drastic and very in-depth. We thought that the process would take for many years because the European Union tends to put a lot of red tape on its actions. However, those actions are gaining momentum. I don't know if you can see what I'm showing right now, the papers, but this is the roadmap. This is a plan for a joint HTA created based on dedicated methodology by mid next year, actually. It's quite surprising because we had another meeting of our work group. It took place on Thursday, and we were informed that the methodology is already finished, it's completed. We still haven't been informed about what that methodology is like because I haven't read the document, but the works are performed in such a way that we talk about the general issues and all the details are developed by the task forces. And then all the efforts are summed up. Definitely, the model that is being created will be a model which functions, which is based on a network of agencies which will cooperate with one another. And of course, it will involve the national efforts. Our group uses what is called PICO. However, you shouldn't be hung up on the classical PICO scheme. This is a modus operandi consisting in the fact that each member state, when selecting the set of assessments, will be able to add their comparator to the general PICO. So we are definitely going towards the creation of an agency or a structure which will be an international structure. So national agencies will be included in a mechanism which will accelerate and foster the HTA process. If I were to create the flagship of the future of HTA, what colors would you say there would be? So I'd say three needs, so three colors. So we see three needs. We see the need for improving the clinical assessment because RCTs are associated with uncertainty. So the registration trials are often too short. They are not. They are a single-arm study, so they don't answer all questions. Then the question of implementing a given technology. So the implementation, practical implementation into the system, we implement our technologies different to other countries, which results in different outcomes. So we can see that implementation even across Polish regions is different. At the European level, we will not be discussing efficacy. The third issue is that the assessment will shift towards two tiers. On the one hand, we will be wanting to improve evidence, but we will also like to measure the value within the systems. So in the systems, we will be focusing more on value-based healthcare because we will have more digital tools. The awareness is greater. Of course, I'm talking about a long-term perspective. Actually, it's a perspective which is going to happen very soon. So as part of the joint HTA, what is underlined is the meaning of creating models as the mode of working on clinical data. That results from the fact that we are observing more and more single-arm studies. I don't know if you know, but 60% of cancer trials registered by the EMA are single-arm studies. You deal with HTA, so you know that work on HTA based on single-arm studies, it's difficult to perform assessments. What is being underlined is the development of AI, which will have huge consequences on the entire HTA market. Why? Because AI is the perfect HTA maker. They are the model HTA creator. What is it characterized by? It's characterized by full, comprehensive, instant access to the full medical knowledge, Furthermore, it can interpret and will be able to interpret even better in the future phenomena which happens in the clinical process. They will be able to bring into one point the entire knowledge on a specific topic and will be able to assess that knowledge. So in the long term, the role of an HTA analyst, it might become obsolete. I'm skeptical. I would say that for the next decade, analysts are safe because the methodology is still not there. Definitely, no one's questioning that, but I would like to say what the ideas for the future are. So who is cheaper, an analyst who is plugged into a socket, or an actual flesh and blood analyst who gets sick, who gets pregnant? In the long run, it is inevitable. This process will not be stopped. The element which is associated with it is limiting the demand, the supply of studies for the market, because with automized tools, the demand on the market for such analysis, especially in the clinical aspects, scoping documents, similar analysis, will be much less in demand. We should be aware of that. EU's movement towards creating a joint HTA will certainly be determining the markets in which we will function. It will not just impact HTA agencies, which will have to find a new way, but it will also impact the pharmaceutical industry. Pharmaceutical companies in Poland and abroad will have a changed structure, so they will not need so many market access specialists and many HTA experts, because the system will look more like EMA rather than the dispersed local agencies. So we will also be experiencing significant changes in the structure and organization of pharmaceutical companies. The role of key experts will definitely be of even greater significance, because with a lot of automized systems, at the end, we need someone who will be able to put a bow, a ribbon on the whole process, to perform a final check. So key HTA experts are looking at a bright future right now.
I'll hand over to Michael in a moment, but I think we have 3 levels of the implementation-related program. Yes, we will arrive at this model, not just in HTA, but in any type of analytics. It's just a question of time. AI, intelligent networks, deep learning, they learn at 3 levels. They learn on their own, but they also learn by confirmation, which is about what we see. Even current tests, you can run on GPT chat, you can try running different analyses there. So the question arises, the level of complexity, and Michael can say more about this, is growing, and it's a long way ahead for AI to learn all the levels of complexity. So 3 issues arise. What do we want to compare? How do we compare? And over time, AI can help us out here. 2, what results do we have? These are determined by the quality of data, and this is a long path to cover, because data is uneven, it is an unequal quality. And then 3 differences in quality of care. It's different in Poland and Germany. We have the assumption, Jacek, that we have similar treatment for patients. But no, that is not the case. There would be such significant variance that we will have difficulty in generalizing results. So evidence, understood even as standard RCDs, will remain key for us. What will definitely change is that it will be easier for us to draw conclusions about the progress, the consequences of an illness. Registries will be replaced by AI analyses. This will make it easier for us to assess the situation. This includes costs, who, how, at what age. This does not change the fact that over the next 5 to 10 years, we will be dealing with methodological issues to make sure that the data is robust enough for us to draw reliable conclusions. We have just tested RWE, real-world evidence, and the data is so discrepant. Even if AI is capable of identifying certain things, this was too difficult because data was divergent at the level of registry. And if we add cost to that, if we look at cost effectiveness, we have to go to even more complex models. And one more thing, we're talking about the horizon that we are starting to repair. We're looking back at what we've been doing to this point, and we can see how much work we have ahead of us to provide reliable conclusions. So we're at the outset of our path. I'm not pessimistic. We're not
Jeżeli chodzi o pesymizm, to mam jeszcze część demograficzną.
This is not the end. By no means is this the end. But looking at the fact that AI will replace certain areas, we will all have to use it. The question is, in what scope, for what purposes? I don't know if you're testing AI. I have the opportunity to do that. AI is like an iPhone. It's so easy to use. It's so pleasant to use. But the question is, do we understand the data it's providing us with? And this is what analysts have a lot of room for work. We had a workshop with representatives from the UK in using AI in economic models in health economics. And it was obvious that there are so many errors at so many levels. The whole structure of the model is still a very creative process, and it has to be well thought out. There are so many aspects to it. So I'm not
Magda, nie musisz się
afraid
bać, bo jesteś
I have a
kluczowym
job till I
ekspertem, więc ty
die.
będziesz
You're a key expert,
królową tego
Magda,
systemu.
so you will be the queen of this system. I'm not afraid, I'm not scared. I hope you're not, ladies and gentlemen, but we will start working with different data in time. Michael, over to you again. You talked about value in HTA, especially in our part of the world. We look at cost, we look at effectiveness, and that's it. And we don't go any further. We don't look at accessibility, at inequality, at different aspects of equity. So, Michael, please tell me, you listed MCDA. Different countries are trying to build it. Poland, well, we don't really want to go into MCDA, though we have a rare disease plan, and we have an MCDA there for drugs. But how do you think countries will cope with that? Germany, for example. Germany is quite restrictive in terms of HTA assessments. You're not measuring accessibility, though as a wealthy country, you don't have this problem. Do you think, Michael, that over time, in the context of Germany withdrawing certain products, for example, Amno has been withdrawn from the market, which follows from the approach to price and accessibility. So, Michael, do you think that over time, Germany will go into budget impact analysis, looking at whether you can afford it? Can this complement this way of thinking? If we're measuring budget impact, then maybe we should look at inequality, accessibility. When do these patients enter the system? And can we measure value additionally to that?
Okay. Magdalena, this is a range of questions indeed.
Yeah, I know.
Let me try to answer a few of them.
and speculate about a few others where we don't have the answers actually. Before doing that, just one remark regarding the HI discussion that I followed with high interest. I think these visions that you shared are really fascinating ones. And I think indeed there is potential for HI. In particular, I would see that in the field where we are currently abusing junior analysts. You know, we give them a cookbook and we give them standard approaches, and then they have to develop HTA or value dossiers, if you take the industry perspective, in a fashion that is almost assembly line. But even there, we have a whole range of judgments that enter the model, and the models being used, there are structural uncertainty, not only parameter uncertainty. You need somebody who is controlling what's going on, and I don't think HI can replace these parts of the process, at least not in the foreseeable future. That takes me to MCDA. I mean, you could even say HTA by definition is a form of multi-criteria decision-making. Should be. Well, in countries like the UK, where you have that formal separation between assessment and appraisal, at the very latest in the appraisal stage, this is a form of multi-criteria decision-making, even though perhaps not quantified. In the German system, which you asked about, we have a similar setting, but it's just two separate institutions. We've got usually the EQUIC that is being commissioned to do the assessment, the classic HTA, but the actual decision-making body is a joint federal committee. Here we have representatives of providers as well as of payers, 50-50, and some neutral people. Patient participation, interestingly, as an aside here, is limited in Germany. There are patient representatives, but they have no voting right. So this is something that is certainly not ideal, but what we see is that the Joint Federal Committee that has to make the decisions about the level of benefit of a new technology, which then translates into pricing negotiations, which is still a separate step in the German system, that these decisions in about, well, 12-15% diverge from what IQWIC says. So this is not consistent, actually. The deliberation at the Joint Federal Committee fairly frequently leads to deviation from what IQWIC said. Yeah, this is kind of multi-criteria decision analysis being observed in action here. I doubt that the deliberation, and it's essentially a deliberative process, and I believe you will be talking about evidence-informed deliberative processes later during this symposium as well again, right? I don't see how these could be replaced by HI at the end of the day. And then the HI probably has a structurally conservative element in it. It can reproduce what's already out there, but when it comes to innovation, to develop concepts, I'm still skeptical. I mean, we cannot rule out what things look like in 20 or 30 years. Yeah, exactly. We will see, but that's a speculative part. I have a certain dose of skepticism here.
Okay, we have 5 minutes. Mamy 5 minut do końca. Proszę Państwa, może jakieś pytanie z sali?
Ladies and gentlemen, perhaps a question from the floor. Anyone from the audience would like to ask a question?
Mark.
Thank you. This is Mark Parker. I'm presenting tomorrow, but this is very much to Michael. I think first of all, I want to really agree with you on the need for discussion around numbers of patients. So how how wide a population does an intervention come to numbers of patients on the sort of individual patients, so the rare disease versus wide populations, so your diabetes and your sort of heart disease, those kind of aspects. I think that there is a need to academically assess that and bring that into the decision-making process. I think you're absolutely correct at that point. But one thing I noticed in your presentation, and I think was missing from this morning, and it was very quickly touched on in the first presentation, is this concept of disinvestment and opportunity cost. So, and it really stood out on the slide where you were talking about the £250 for the single patient, and this is £250,000 for the project. From an HTA perspective, I think what gets lost a lot of the time is, that's £250,000 not being spent on something like cataract surgeries. So I think that I think there is a real need from a threshold perspective to understand that threshold is what we are giving up from the rest of things that we've measured. And I think I think my question on that aspect was, if we're not there, how do we get there? And what kind of process from the things we've discussed this morning do you think will improve that situation? Thank you.
I agree with what you have said, and I can only say I exceeded the time that I was allowed to talk by quite a margin. If I had got into the topic you raised, I'm not sure how long it would have taken, but I agree the disinvestment issue is a major one, but it has so many facets that I think I should not start to embark on that, because whatever I say will necessarily give rise to the criticism, well, but you omitted some other important points. There's a whole range of things, from defining what should be displaced up to actually implementing that. We all too often do that in a way that is intransparent, happens haphazardly, and long story. But I totally agree, a big topic. And related to that, maybe one remark, we are also there's a cartoon, I'm not sure how you would describe that, but I'm sure all of you know that there is a person who has lost a key, and they are looking for the key where there is a lamp on the street, where there is a light. And where there is no light, they don't look for the key. And it's kind of a bit of, well, we pay a lot of attention to a certain part of the new technologies that are coming into the system, but we keep in the dark major other parts, where there is a lot to gain in terms of efficiency for sure.
Thank you very much. Bardzo Państwu dziękuję za pierwszą sesję. Zapraszam.
Thank you so much for the first session. In just a minute, we're starting the second session, which will discuss the international development of HTA. And we will be talking about joint clinical assessment, but also EHDS and different directions of HTA development. We will include the pharma industry perspective. Thank you for the first session, and please join us for the second one.